the arrhythmias can complicate the course of patient with standing, even they come before the hospitalization, even during the treatment, they can be seen, or even after the treatment, some sort of arrhythmias can be seen. It can be either some form of bradyarrhythmia or it can be some form of tachyarrhythmias also can be that. And the major problem is that the arrhythmias can provoke some sort of hemodynamic consequences. So what sort of hemodynamic consequences? So patient with LV dysfunction, usually they have a strict stroke volume. The range of heart rate with optimum cardiac output is very narrow. So either a faster or slower rates can decrease the cardiac output. Thus all form of tachycardia and bradycardia can depress cardiac output in the patient of STEMI. Second factor to consider is the loss of atrial contribution to the ventricular preload in case of arrhythmia. The loss of atrial transport decreases LV output by 15 to 20% in any scenarios, including STEMI. Heart rate is one of the major determinants of the myocardial oxygen consumption. More rapid heart rate elevate myocardial energy needs and hence it can adversely affect the myocardium. In the patient with STEMI, the usual consideration of permissible heart rate limit would be around 60 to 80 beats per minute. Directly going towards the ventricular arrhythmia, we'll begin with the very benign one, that's the VPCs or ventricular premature depolarizations. In very brief, they have a wide QRS complex, STNT, UAV discordant, and QRS complex is usually followed by a pause. So, what would, in the earlier scenarios, the VPCs with following features were considered to be with slightly higher risk. That features would include a frequent VPCs, that is more than 5 VPCs per minute. VPCs with a multiform configuration, early coupling, R1D phenomenon, and a repetitive patterns in the form of couplets or triplets. But the thing is that the patient with such VPCs might not have developed any VF or ventricular tachycardia, and the patient without such patient who are not showing this arrhythmias can directly show precipitation of VT or VF. So basically nowadays it is considered as, does not consider as a warning arrhythmia as this VPCs. It has very low sensitivity and specificity of electrocardiographic patterns observed in the monitoring system for identifying patient at the risk of VF. So what is the management part? Now it is not considered as a precipitating or a malignant VPC. So
then which are the dangerous VPCs? If those are not, then which are the dangerous?
So these features were considered to be dangerous.
These were considered, but as you said, now they are not considered. So is there any dangerous VPC that we should be looking for?
VPCs as such are now not considered as dangerous.
So we are in salvo or low runs of VP. It's not considered.
No, sir. It clearly mentions that even if the couplings and tripling patterns are nowadays not considered as a precipitating factor for VT or VF.
So NSVT is considered dangerous?
NSVT would be considered precipitating factor, sir. Yeah. So now after the reperfusion therapies, the incidence of VF in patient presenting with VPCs have declined significantly. So the prophylactic suppression of VPCs with anti-arrhythmic drug is now not indicated. We would generally pursue a conservative course in a patient with STEMI and VPCs and do not prescribe any anti-arrhythmic drugs other than the beta blockers, and would try to correct any underlying cause such as ischemia or electrolyte or metabolic disturbances that might have caused the VPCs. Second pattern of ventricular arrhythmia, that is accelerated ventricular rhythm. That's basically a ventricular rhythm with rate between 60 to 100 beats a minute. Typically, it's in the first 2 days of the MI, and it occurs with above equal frequency in the anterior and inferior wall of the partial. Usually, the episodes are brief, and they are often seen even after successful reperfusion therapy after instituting fibrinolytic therapies. However, it's not a constant finding that it happens only after reperfusion, so it has no significance regarding. It cannot specifically say that the vessel has been perfused if these arrhythmias are observed. Nevertheless, in contrast to VT, the ARVR or accelerated ventricular rhythm is not thought to affect any further prognosis, and usually it does not require any treatment unless until it causes any hemodynamic instability. So the ventricular tachycardia and ventricular fibrillation is very brief. The ventricular tachycardia more than 3 VPCs and the rate exceeds 100 beats per minute, that's your VT. A non-sustained one is less than 30 seconds, a sustained one if it is more than 30 seconds. or if it causes some sort of hemodynamic compromises, then the duration is not important. Monomorphic if complexes are similar or uniform configuration, and polymorphic if QRS complexes are different configuration, and maybe it can be non-sustained or sustained also. Ventricular fibrillation is a disorganized ventricular rhythm, poorly defined QRS complex, usually irregular with varying style and shapes. Basically considered as a third terminal rhythm in most cases. So, what are the underlying mechanisms for VD and PF? The major mechanisms for ventricular arrhythmia. The acute phase of coronary syndrome is basically re-entry caused by inhomogeneity in the electrical characteristic of ischemic myocardium. The cellular mechanisms would involve electrolyte imbalance such as potassium and magnesium imbalance and the accumulation of toxin substance and lactate in the myocardium. In the late course of STEMI, the VD and PF are more likely more common in the patient who have suffered a transmural infarction and those who are having residual airway dysfunctions, and they are more dangerous and they are more frequently associated with hemodynamic deteriorations. Prophylaxis, because the hypokalemia can increase the risk of development of VD, so low serum potassium levels require prompt identification and treatment and after admitting the patients of STEM. Usual potassium levels are safe potassium levels are seen as between 4.5 to 5.5 is considered as a safe potassium level. Hypomagnesemia can also precipitate VD, and reduced magnesium levels are not adequately reflected by serum magnesium levels. Nevertheless, the magnesium levels should be repeated and achieve a serum magnesium level of 2 milliequivalent per liter. Early beta blockers can also be used to prevent episodes of VD and PF if they are not contraindicated by any other means. The previously practiced thing about lignocaine prophylaxis is nowadays not preferred for prevention of VD or PF in a patient of STEM. Management, as we all know, if the VD or VF is happening with hemodynamic instability, then it comes, the ideal treatment is electrical cardioversion. Second thing would be administration of IV amiodarone can facilitate. After achieving the sinus rhythm, the goal should be directed towards identifying the underlying abnormalities and correcting those such as hypoxia, hypertension, acid base or electrolyte disturbances, or maybe digital excess. Urgent revascularization is warranted if the arrhythmias are being caused by the ischemia. Now, after the acute phase is over, the extended use of anti-arrhythmic therapies, usually the amiodarone is continued to a certain period of time, usually till a defibrillator is faced is warranted. This is just in brief acute management of any wide complex QRS tachycardia. We have mentioned the hemodynamically unstable, then we directly go for electrical cardioversion as per the ACLS guideline. Otherwise, we can follow the protocol and go for the medical treatment as it shows. So these are the 2017 PCS guidelines for management of ventricular tachycardia in a patient of STEM. Again, the beta blocker has a class 1 indications for treatment as well as they are useful for the prophylaxis also. The proper revascularization is again also class 1 indications. Intravenous use of amiodarone to recommended for the prevention of recurrent polymorphity, again class 1 indication, and correction of electrolyte imbalance and any underlying causes is a class 1 treatment in case of VD or VF in a patient of STEM. Again, the class 2 indications, amiodarone is a class 2 drug, level of indication is class 2 in case of recurrent VD. Other treatments available are transcatheter, termination, overdrive pacing, radio frequency ablation can also be done, that's a class 2 indication, recurrent VD and hemodynamic suppression despite electrical cardioversion and treatment with beta blocker and amiodarone. There comes the use of lignocaine or what can be used. Now again, the prophylactic treatment with anti-arrhythmic drug is not indicated, it may be harmful, and asymptomatic patients with hemodynamically irrelevant ventricular arrhythmias such as AIVR should not be treated with anti-arrhythmic drugs. Long-term management of ventricular arrhythmias and risk evaluation of sudden death. This is again 2017 ECS guidelines. ICD therapy is recommended to reduce sudden cardiac death in a patient with symptomatic heart failure NIH 2 to 3 with IV dysfunction of EF less than or equal to 35% despite optical medical therapy for more than 3 months or 6 weeks. There were class 1 indications to undergo ICD implantation and IVC implantation for or temporary variable use cardioverter defibrillator will be considered in less than 14 days of MI patients. That's a class 2B3 indication. That's the algorithm that can be followed in a patient of STEMI or LV dysfunction for primary prevention of sudden cardiac death. If the LVEF, baseline LVEF is less than 40, then we see the MI or revascularization process was done under 40 days. Then the patient should undergo EP study, especially if there was some sort of episodes of angiospermy during the admission. And that if the EP study is showing inducible VT, then ICD insertion is a class 1 indication. The patient can either go under guideline directed medical therapy also, or it can also have a variable cardioverter defibrillator. And the risk of sudden cardiac death can again be reassessed after 14 days of MI or revascularization. Again, if we are thinking about a scenario that is more than 40 days after MI or revascularization, then if the EF is less than 30%, and even if there is MI class 1 dyspnea, then the ICD becomes class 1 indication. EF between 30-35 and MI grade 2-3 dyspnea, again ICD is a class 1 indication. LVEF is less than 40%, there was some sort of NSVT observed, and inducible VT is observed during the EP study, then again ICD becomes a class 1 indication. And if no, if the EF is less than between 35-40%, there was some sort of NSVT evidence, and the EP study does not show any inducible VT, then patient can go ahead with the guideline directed medical management. Now the NOH class 4 candidate with advanced heart failure therapy, they can go ICD implantation with the class 2 recommendation. That's the secondary. Now we're talking about secondary prevention in a patient with IHD or sudden cardiac death. Those who have survived a sudden cardiac arrest or those who have suffered a sustained spontaneous monomorphic VT and it was caused by the dystonia. If the revascularization is warranted, then again we should go for the first for the revascularization, and we can follow the previous protocol for the patient. If somehow the revascularization was not possible or not indicated, then the ICD, if the other indications are there for ICD, then ICD insertion is a class 1 indication. The patients with the cardiac syncop and LVEF 35 less than 35%, then ICD again is a class 1 indication. And if the EF is more than 35%, then you have to go for EP study if it shows any inducible ventricular arrhythmia, then ICD again becomes a class 1 indication. If not, then it can go extended monitoring also. Prognosis of the patient who underwent fibrinolytic therapy in this two trials I have mentioned. Those are after the patient who underwent fibrinolytic therapy. About 10% showed experience of BTVF in Ghost-1 trial and Apex MI trial, and 5.7% showed BTVF trial. The patient with VT and VF definitely had worse clinical outcomes than those who did not have VT or VF. The mortality rates were higher in those with late versus early VTEF, especially when compared to the patient without VT or VF. The adjusted mortality ratio at 90 days increased twofold in the patient with early VT or VF, or it was sixfold in the patient who suffered late VT or VF, that is more than 48 hours after the insult. The patient whom sustained VT/VF developed better in the course after study for 48 hours without evidence of any other reversible cause. As we have mentioned earlier, the ICD therapy for secondary prevention should be considered before discharge.
So, see, no patient who develops the ventricular fibrillation, sudden cardiac arrest due to ventricular fibrillation, 48 hours of the chest pain or infarction. Do we give prophylactic antiarrhythmic afterward? It is considered as a primary ventricular fibrillation. Now patient is cured by the revascularization. Now the antiarrhythmic is not required. Previously it was said no antiarrhythmic is required.
So as I mentioned earlier, usually the antiarrhythmic therapy in form of maybe oral cortisone can be considered to a certain period of time. And if the patient is a candidate of ICD or not, that can be discussed as per the
the revascularization is done. Now patient is absolutely alright. And after 48 hours he doesn't show any ejection fraction is normal. It doesn't show any signs of
and there is no other indication of ICD implantation or no other pressure reading for was visibly appearing of that of any anterior. So to be honestly, I'm trying to find out that category in particular.
Initially, we were taught.
Yeah.
Within if ventricular fibrillation occurs within 48 hours of infarction, antiarrhythmics are not needed. Revascularization is done and patient's ischemia is restored. What is the status of that?
Sir, then it depends on the LV function. If your ejection fraction stays below 35, even if that patient you revascularized, then it is indicated according to this chart.
No, ejection fraction is normal.
Ejection fraction normal हो गया तो उसका आंसर क्या है?
So to be honestly, like I'm still clear on that part. The only thing I found mentioned in the ruler was that if the patient has suffered some sort of evidence of VD or VF during the MI or any activity by, and as you said, there is no later on indication for ICD or
Because
any disability factor.
Many patient presents.
Then there are, I didn't find anything that I could maybe Dr. Mirza can have those.
Actually, there are two kinds of arrhythmia. One is ischemic VT and one is reperfusion arrhythmia. So, if patient is suffering from ischemic VT during infarction, patient is suffering from VT, then we should give antiarrhythmic. If it is reperfusion related arrhythmia, while in cath lab or asking within.
I am talking about long-term profile. Whether
That's what I am talking about. If it is reperfusion arrhythmia during procedure or after the procedure 48 hours, there is reperfusion related arrhythmia. So, because electromechanical circuit is there after reperfusion, the potassium and the magnesium imbalance is there. So, it restores over a period of time. That patient doesn't require any arrhythmics.
I am talking about the person who presents with ventricular fibrillation, hypertension, infarction. Immediately that patient is taken for revascularization, and after that ejection fraction is normal. No evidence of the cardiac size is normal. There is no dilatation.
Sir, if patient has suffered arrhythmia during the period of infarction, that patient doesn't recover. His EF also doesn't recover very fast. That patient requires antiarrhythmic for certain period of time till his ejection fraction improves. Because that patient suffered a massive MI and they recover slowly.
No. See, sir, question is very particular. You try to imagine a condition that sir is there in his nursing home. At 12 a.m. midnight, a patient comes with anterior MI. Okay. While the time sir plans to thrombolize, patient goes into VT.
No, not thrombolysis. Patient present with ventricular fibrillation.
Okay.
You gave DC shock. Patient is all right. Now you found that patient is infarct. Immediately revascularization done and post-level echo is normal.
That is
That is because many patients present is like this.
So that is known as primary VT and secondary VT. So sir is asking for primary VT whose ejection fraction is now restored to normal with reperfusion.
Then that patient doesn't recover.
Okay.
But to be
What
like,
is the
my
nature
side, I would
of
say
such
that
patient is to be studied. You see, if you know the natural history, then your thought process of intervention comes as such. If this subgroup behaves benign, probably you don't require any intervention. But if the natural history shows that at a later date, because nobody knows the natural history of such patient. So whatever you are doing is on an assumption rather than evidence. Your gut feeling says you do it. Gut feeling says no, don't do it. Because where the literature is.
I think honestly, sir, that category would be some sort of rare phenomenon. The patient has suffered massivity and absolutely.
Not by vaccination, natural history first. Understand?
And to be honestly, I have even tried to identify any particular guidelines available for that category of patients or not. I couldn't find anything apart from just small paragraph written in the book was that anti-arrhythmic therapies can be continued to a certain period of time following such insults. And the ICD indication is a separate thing that can be considered as per those parameters. I think so.
As such, the ICD
Yeah,
consideration is most of the time after 3 months of
After
3 months of everything.
Yes.
And during those 3 months, if the ejection fraction is normal and the hemodynamic, you are not going to do anything.
See, ICD indication.
Actually, so there are in USA they prefer wearable ICD for 45 days.
Once again I am coming. That ICD indication is recommended by whom? There is conflict of interest or not as such. If it was sponsored by the ICD company as such, You see, your recommendation will come definitely. You eat in a 5-star hotel as such. As I told, the natural history you must know it as such, and then the intervention comes.
Definitely. I think we can go ahead with the next part. That will include the periodic arrhythmias. First, again, very benign form, the sinus periodic arrhythmia. Others during the early phase of
Before
study.
that,
Yeah.
when you talk about beta blocker first,
Yeah.
which beta blocker?
So, in case of STEMI, I would use the one who have evidence of myocardial saving with that would metoprolol, DMC carvedilol, and the third one I am not remembering.
IV is only metoprolol.
IV is only
IV
metoprolol.
also-
No, obviously we are going to use IV metoprolol.
No,
That's a metoprolol.
IV is smaller.
No, sir, IVS for is for AF and SVT. It is not
Agree. Fastest acting beta blocker is this one,
smaller.
right? And when the time is running out, if you use metoprolol, it takes time to act as such.
Do you have any trial with IV small? Do you know?
We have used left, right, and center.
Huh?
We have used left, right, and
No,
center.
the point is most of the trial are with the IV metoprolol.
Metoprolol only, sir. I have no.
Because we are all time.
Once again, food for third.
See, AstraZeneca came and displaced the smaller. As I told you, conflict of interest you have to see in between us.
But smaller is a very stringent indication.
Right, see. Now probably available or not is again question.
Yeah, it's available.
We can go ahead.
Yes.
So, the next part is the periodic arrhythmias. Most benign form of sinus periodic arrhythmias, as we have mentioned earlier, it occurs during the early phase of STEMI most frequently, and it's more common in the inferior posterior infarctions. And acute mortality rates are similar in the patient with sinus periodic arrhythmias and those who are without it. So, the management part, again, the isolated sinus periodic
Sorry, one
arrhythmias.
second.
Yeah.
You are reading the slide.
Okay.
You address the audiences.
Okay, no problem.
Right, I'm sorry, but then I was just seeing that you are reading the slide as such. Suppose the slide is not there and slides are not there.
Okay, sir, permission.
Right? That will translate the knowledge much faster and much easier.
Communicating.
No, point noted, sir, definitely. So, once again, the isolated sinus periodic would not require any significant treatment. If they are not severe, such as the heart rate being less than 40 or 50%, or if they are causing some sort of hemodynamic instability, some sort of symptoms related to decreased heart rate, or then the IV administration of atropine 0.3 to 0.6 milligram every 3 to 10 minutes, not exceeding more than 3 grams, milligrams, sorry, can be tried in those patients. While in
Meeting
severe
માં
patients,
સરળ પછી
The retropine will be higher or higher?
હેલો હું મીટિંગમાં છું 9:30 પછી આવીશ.
Now we'll be going further in the atrioventricular and intraventricular block. So different sort of block including the entire conduction system of the heart can happen in patient of stent. That's basically the idea about this slide. So that's just two most common form of blocks. What is the proximal block and distal block in this side? Anything beyond the bundle of disc is considered as a distal block. Anything beyond anything proximal to that but is considered as a proximal block. Now, the proximal block are more common with inferior posterior infarction, and hence they are more common in, they relate with the appearance of RC and LCX. While the distal blocks beyond the bundle of disc are more common with anterosacral infarctions, and they are caused by the sacral perforations of LED ischemia. The mechanisms for both type of blocks would be the same.
અરે હું મીટિંગમાં છું પછી વાત કરીશ.
Mechanisms for both the types of blocks is just the same. It can be ischemic infarction or something else. Now the proximal blocks are usually present with the first degree block or a type 1 Mobius type 1 second degree block, while the distal blocks that is beyond the bundle of disc, they usually present as a Mobius type 2 or a third degree block. Now again the proximal blocks, they have narrow QRS complex and the escape rhythm is somewhat stable, like 45 to 60 beats a minute. It's It has a tendency to go towards a complete block, but it's lesser as compared to a distal block. We'll see the management part later on. While the distal blocks, they have a wide QRS complex, often the escape rhythm is less than 30 heart rates, and the high tendency to go towards a systole or complete heart block. So basically, they are the more malignant sort of blocks. We'll see that in the later on slides. Again, the first degree AV block. The first degree AV block is a simple PR prolongation and usually does not require any specific treatment. Causing factors apart from ischemia could also be the use of beta blockers or any calcium channel blockers other than dihydropyridines. Now, that was a good thing mentioned in the report was that if we see a first degree block in such patients, do we stop those beta blockers and something like that? So, unless until the PR interval is not more than 24 seconds, if the patient is asymptomatic with first degree heart, then it is better to continue with beta blockers or calcium channel blockers or you are using for those patients. Those agents should be stopped if the PR interval is more than 0.24 seconds in case of first degree heart block or if there are any symptoms present. Again, for the treatment part, atropine can be used in symptomatic patient. The most important part would be some aggressive sort of electrocardiographic monitoring is required in those patients because they have a tendency to go towards high degree of blocks. Type 1 second degree block. Again, usually does not affect survival, most often associated with the RCA infarct as we mentioned earlier, and the underlying mechanism would be the ischemia mode. Again, the specific therapy is not required unless the heart rate is below 50 or if the Mobius type 1 block is associated with some sort of other ventricular illness such as PTCs or it shows heart failure or any other hemodynamic instability. Then the type 1 secondary block would require some sort of treatment. And again, the primary treatment, the first line of treatment would be IV atropine 0.6 mg. And temporary pacing is rarely needed in case of the second degree type 1 AV block. Type 2 second degree AV block. Okay, if it occurs in the setting of inferior and posterior stemming, it is usually temporary. It has, as we have mentioned in that chart, it shows a narrow complex junctional escape rhythm. It can be managed conservatively with aggressive electrocardiographic monitoring. Type 2 degree block developed in a patient of anterior or lateral wall stemming. The lesion is usually the conduction system below bundle of fist, and it has more tendency to go towards complete heart block or asystole. And the patient who are having anterior wall stemming and type 2 degree block, that would be considered more malignant and they would demand some sort of temporary pacemaker insertion. Now, the complete heart block or third degree heart block, this is just electrocardiographic features of complete heart block. You can skip that slide. Now, again, if the CSP is occurring in the setting of, it can occur in inferior posterior wall MI. But in the inferior wall MI, it usually develops gradually. It usually progresses from either first degree or type 1, which type 1 secondary block. Again, the mechanism is ischemia infarction of every node. Again, the junctional rhythm would be a narrow complex QRS, and the baseline rate would be somewhat better than those we can see in the CSP with MI. That is, the ventricular rate is seen somewhere around 40 beats a minute. In most of the cases, somewhere around 70% of the cases, CSP in inferior MI present with such sort of lesser malignant features. It is often transient and can resolve within a few days. Patients with inferior stemming and AV blocks, again, those patients who are presenting with CLP and inferior MI, and those patients who are just presenting with inferior MI. The one presenting with the blocks, they have high degree of infarction and hence somewhat lesser better prognosis. As I mentioned earlier, the pacing is generally not indicated in patients with inferior MI and complete CHP if it is not causing any hemodynamic instability. Or temporary sort of pacemaker is indicated if there is symptoms or hemodynamic instability related to CHP. Now again, some interesting thing mentioned in the group was that if the CHP is occurring within the 6 weeks or within the 6 hours of infarction, then the atropine is likely to show a good response. CLP developing beyond 6 hours of STEMI or inferior wall STEMI, the atropine is less likely to show any good response, or it is likely to show a lesser sort of response. Now, CLP is setting of anterior wall
Where is the
infarction.
block? Where is the block?
Sorry.
Complete heart block is where is the block?
There is anything beyond
Bundle of his,
yeah,
right?
yeah,
And Vegas do not work there.
yeah. So,
So
this slide,
atropine, how is going to work?
yeah, atropine is not going to work. And the point of this slide is only that if your atropine has worked, then it was very likely that the CLP was going to
You are trying, otherwise,
yeah,
Vegas has no place now.
definitely. So, now again, the CHP in anterior wall infarctions, it's a more sort of more malignant as compared to those we can see in inferior wall infarction. Usually, can happen spontaneously after 10 to 24 hours, and it can happen spontaneously, or it can happen after like 2 second degree heavy block. Again, we have mentioned, as we have mentioned in the earlier slide, then escape rhythm would be with a wide QRS complex, and ventricular rate would be somewhat lesser than those we see in escape rhythm of inferior wall MI. And these blocks have a higher tendency to go towards the CLP or asystole, and this patient would definitely require pacing. But again, as they mentioned in the group blocks, the pacing changes any prognosis or not. That's a controversial thing. But so now the interventricular blocks. Now we'll be talking about the fascicular blocks and the bundle branch blocks later on. They can also happen in the patient of STEM. Not all the blocks in the STEM have the complication of infarcts. And compared to those patients who do not have any blocks, the patient with any sort of block is definitely going to have a high degree of induction, some sort of lower EF, and some sort of lesser prognosis. Now, isolated fascicular block, isolated left ventricular or left posterior fascicular block. Any isolated fascicular block usually slightly higher mortality than those who do not have any sort of blocks. Okay, but complete AV block is uncommon phenomenon in a patient with a single vascular block. RBBB can be RBB can be baseline for
Compare with the previous cardiogram.
yeah.
If you are having previous cardiogram,
Then it's a very valuable thing.
alright, then if he had RBB and now RBB,
Yeah, then it's not.
it has got no meaning.
Yeah, it has-
LBB and now LBB, it has got no meaning.
Yeah, and again, when I think mentioned before that even if the RBB is present, it is likely to hamper your prognosis only if associated with heart failure, and the patient is absolutely stable without any heart failure, without any hemodynamic instability, and he wants the RBB associated with the ACS, the prognosis might not be that poor. So now the bifascicular block such as RBB with a left anterior or left posterior fascicular block or any LBB. So if any new block occurs in 2 out of 3 divisions of bundle of Hish, the development of AV block is quite high, the infarction level is quite extensive, EF is quite low, generally in those sort of patients, and that would definitely have some sort of poor prognosis. Again, those who already have evidence of bifascicular block or something like that, they are not considered as any additional risk factors. So, bifascicular block, again with a PR prolongation, it can be considered as a bifascicular block. That's one thing in that. So, any of the various forms of trifascicular blocks associated with trifascicular block patterns are more commonly associated with the anterior infarction than the inferior posterior infarction. And as again mentioned previously, there were larger infarction area, poor EF, and worse prognosis. Now, the last area is presence of asystole. The only thing I would like to mention is that it's not always going to be asystole, it might be a fine PF. So, if you are suddenly asystole, then there is no harm in trying with electrocardiogram electroversion of that patient. So now, in very brief, the use of pacemaker those who have AV block in just only one of the three vesicles, those who are having pre-existing bifascicular block, they usually do not require any sort of temporary pacing. About the permanent pacing, we can, I think so, we can directly go towards the recommendation. The class 1 recommendation for permanent pacing in a patient with Stanley and arrhythmia. Those with the second degree block and alternating Butterbrand block, class in class 1 indication. Transient second or third degree block associated with the Butterbrand block and side is confirmed discovery under test with the study. Again, they have class 1 indication for permanent placement consultant. And those with the persistent symptomatic second and third degree block, newly developed second and third degree block after ACS, they have a class 1 indication for permanent pacemaker insertion.
Persistent means how many days?
Sorry.
Persistent second or third degree, how many days?
So
After reversal.
I think so. Like inferior wall is 6 days. I'm not sure about that.
Actually, there are no guidelines.
Yeah.
In anterior MI, the third block is worse, so they wait for 3 days
Okay.
and then advise for permanent pacemaker. In inferior MI, chances of recovery is higher, so they wait for 7 days.
Okay. Very brief supraventricular arrhythmias. Again, the benign one, sinus arrhythmias. Basically, the slide would like to share that the ischemias might not be the only cause for causing those arrhythmias. It can be due to anxiety, it can be due to pain, it can be due to failure, it can be due to associated some sort of infection. So usually you try to identify the cause and treat the cause for sinus tachycardia. Of course, if the beta blockers are not radically, then that use is always indicated. Now, I did flutter fibrillation, I think so. You can directly go ahead with the recommendation. So, yeah. IV beta blockers again are class 1 indication. IV antiviral class 1 indication in this intravenous digitalis should be considered in a patient with a low AF and the AF with the class 2 recommendation. Now the recommendation for cardioversion